Hi, welcome to the MSGERC Grand Rounds Webinar series. Candida auris, everything you always wanted to know about this superbug, but were afraid to ask. Alrighty, so let's begin once again. Welcome to the MSGERC Grand Rounds Webinar series. Today's topic will be Candida auris, everything you ever wanted to know about this superbug, but were afraid to ask. And I'm joined today by Drs. Lyman and Dr. Yoon, who will be co-chairing this meeting with me. Next slide, please. And I do want to mention this is a different type of MSGERC Grand Rounds webinar. We're actually very excited because we were able to take questions as you were registering for this event. And what we're going to be focusing our attention today is going to be answering the top 5 questions in 3 areas, as you can see on the screen. We'll be talking about epidemiology, we'll be talking about infection control and prevention, and we'll be talking about clinical management of cases. Each of the speakers will address the top 5 questions over 15 minutes, and we will reserve 15 minutes at the end for a live Q&A. You have an opportunity to type questions in the Q&A function, and we'll be asking the speakers to answer them. Again, please write your questions in the Q&A or the chat, and we'll be asking the speakers at the end to address them if they were not already addressed in their sections. And without further ado, I do want to thank a couple of people for the funding for this event. First of all, the Centers for Disease Control and Prevention, who are funding this cooperative agreement with the University of Alabama at Birmingham for education and research in medical mycology. And I do want to emphasize that the CDC is an agency within the Department of Health and Human Services, and the contents of this resource do not necessarily represent the policy or CDC or HHS, and that it should not be considered an endorsement by federal government. So having gone over those disclosures, I want to turn it over to Dr. Lyman, who's a medical officer at the Mycotic Disease Branch, who's going to be taking the epidemiology FAQs. Dr. Lyman, please.
Thanks so much. All right, we'll get started with the first question, which is, what is the origin of Candida auris and what are the current theories? Next slide. C. auris was first described in 2009 from an ear specimen in Japan. And since that time, it's spread across the world, including to the United States, where it was first reported in 2016. Next slide. And whole genome sequencing has revealed that there are 5 genetically distinct clades of Candida auris, which suggest independent and almost simultaneous emergence in geographically separated populations across the world. So specifically, all isolates within each region have been highly related, but across regions, isolates have been much more distinct, like tens of thousands of single nucleotide polymorphisms or SNPs. Similarly, all isolates from cases identified in the United States have been highly related to isolates from each of these regions. So these distinct clades of Candida auris emerged nearly simultaneously as causes of human infections. But why did they emerge so recently? Next slide. And the reasons for this rapid emergence as a cause of human disease are really unknown, and the hypotheses are mostly speculative. So, a lot of things that we think about are, was it always here but not affecting humans? Or was it always part of the human flora but not causing infection? And there's no ecological niche that's known. The natural environment does contain a lot of diverse yeasts, and there are a few reports of C. auris isolated from the natural environment or from animals, but it's not clear if those represented its Candida auris's natural reservoir or downstream effects of humans. And environmental sampling in general has been pretty limited. There's also been increased contact with or intrusion of nature by humans more recently. There have also been changes in the environment like climate change or fungicide use in agriculture that might have allowed it to escape or broaden its environmental niche, especially because Candida auris can survive at very high temperatures and in saltier environments compared to other fungi. And these characteristics have also permitted it to cause invasive infections, even during fevers, when a patient's having a fever, or survive on the skin where it may be saltier because of sweat. So there have also been changes among humans, greater travel and contact that between different populations that may have facilitated emergence and spread. Also, increased antifungal use may have encouraged Candida auris because it's so resistant to thrive. And because all clades share this high resistance, it's thought that it's unlikely that this was a recent development. So lots of theories, but still a lot to learn, and we don't have a very conclusive answer. Next slide, I think we'll move to the next question, which is, what are the risk factors to help identify patients who may be at higher risk for Candida auris compared to other species? Candida auris mostly affects those who are very sick at baseline, especially those with invasive medical devices like feeding tubes, central lines, patients on ventilators, patients with multiple prolonged healthcare stays, and these patients often have other MDROs or have received antibacterial or antifungal medications previously. So some of these might be similar to patients who might have other forms of invasive candidiasis, but especially patients who are requiring high acuity care. But generally, healthy individuals seem to be low risk. There have been several studies that have been done looking at healthcare workers in outbreak settings and have not found that healthcare workers have become colonized themselves. There has not been much research about Candida auris outside of healthcare settings, so we don't know much about the risk of transmission, but it does seem to be low based on our current surveillance. Next slide. And one unique aspect about Candida auris is that we've often found more cases in transmission occur in high acuity post-acute care facilities. So these are long-term acute care hospitals, LTACs, or ventilator-capable SNFs. And this is similar to other multi-drug resistant organisms. And this might be because of the longer lengths of stay at these type of facilities, meaning more opportunities for environmental contamination and spread, or the high acuity of these patients compared to the lower acuity nursing homes, and often less infection control infrastructure and resources in these facilities compared to short-term acute care hospitals. But this is not to say that outbreaks and transmission cannot occur in short-term acute care facilities, because we have seen that, and we have been seeing more of that in recent years. Next slide. And while there have been Candida auris outbreaks in NICUs in other countries, pediatric cases have been rare here in the US, perhaps because pediatric care is generally more separated from the care of adult patients. But in the last year, we've identified the first cluster of pediatric cases at a single facility. All 3 cases were from a single pediatric cardiovascular ICU and a hospital that also had adult cases. All of these patients were less than 6 months of age, and 2 had never left the hospital, which was suggestive of facility transmission, likely introduced to this population from adult patients in the same facility through shared exposures, possibly shared medical equipment. So pediatric cases, high acuity, very sick pediatric patients are also at risk for Candida auris. Next slide. All right, the third question. How has Candida auris resistance changed in the USA since it was first identified? Next slide. In general, you can see our national data through the AR lab network. Most Candida auris is resistant to azole medications. About a quarter are resistant to amphotericin B, and only 2% are resistant to echinocandins, which is considered the first-line treatment because of resistance and toxicity of the other two classes. And there are some regional differences in resistance patterns based on the clade that's circulating, which I'll talk a little bit about later. But it can be tough to assess national trends over time because it may reflect changes in which clades are spreading the most, maybe not actually changes of the organism itself. Next slide. So while echinocandin resistance is still relatively rare, we are seeing an increase in cases, which you can see in the figure on the left, including pan-resistant isolates, which are resistant to all three classes in red, and then echinocandin resistant isolates, which are often also resistant to azoles in orange. And the first pan-resistant cases that were ever identified all developed resistance on treatment, and pan-resistance was not identified in any of their patient contacts or on any environmental surfaces. But more recently, we've identified 2 independent clusters of pan-resistant or echinocandin-resistant auris in facilities in Texas and Washington, D.C., which demonstrated to us that these very resistant strains could spread, including to patients that had never been exposed to antifungals, which is concerning because that means an even greater population of patients are at risk for these very resistant and difficult to treat infections. Next slide. All right, the next question. What clades are in circulation in the US, and does knowing the clade have any clinical or infection control implications? Among the 5 clades, there are 3 that are associated with invasive infections and outbreaks in healthcare settings globally, but also here in the US. That's clade 1, clade 3, and clade 4. And previously, we referred to them by the country where they were first identified. So clade 1 or South Asian, clade 3 African, and clade 4 South American. And there have been a few rare cases of clade 2 or East Asian clade in the US, but it's often ear specimens in people with a history of travel to Southeast Asia, and it's been less frequently implicated in outbreaks or invasive infections. Whole genome sequencing has demonstrated that isolates in different parts of the US are very similar to isolates in these other parts of the world, but this does not reflect that these patients actually traveled from those countries. And these different clades represent separate introductions into the US. And while introductions from abroad are still occurring and are important to focus on for screening, most cases in the US at this time are the result of local spread. And more commonly, we found that when an area detects their first clinical case, it occurs in a patient with no history of travel, and they acquired it locally. And often they're just the tip of the iceberg. The subsequent regional containment response, where they do a lot of screening, often reveals more colonized cases. And as some areas have quite a high burden of C. auris at this time, we've also detected domestic travel-related introductions where C. auris is introduced to a new area from another high burden area in the US. So it's important to be aware of this, especially for screening purposes and in areas with a low burden, to be aware of where they could be getting introductions from abroad and domestic. Next slide. Historically, certain clades predominate in different parts of the US. Generally, clade 1 is circulating in the Northeast, clade 3 is circulating in the Southeast, especially Florida, and the West Coast in California, and clade 4 is circulating in the Midwest. This is definitely an oversimplified version of this because more recently we've been seeing multiple clades in some areas as there have been more introductions over time. But in general, this is what we've seen. And it's constantly evolving. Next slide. And because resistance varies among clades, resistance also varies geographically based on the predominant clade circulating. So you can see that Candida auris in the Northeast, in New York and New Jersey, where the South Asian clade is circulating, is very resistant to azoles, and the clade that's most resistant to amphotericin B. And in Florida, where the African clade predominates, most C. auris are still resistant to azoles, but less resistant to amphotericin B. And in Illinois, where the South American clade predominates, C. auris is much more susceptible even to azoles. However, we are seeing azole resistance increase in this region. And you can see that echinocandin resistance is pretty low across all clades. But there are not different infection control recommendations depending on the clade. And I know oftentimes information about clade comes much later after a case has been identified. Next slide. All right, final question on the epi side, how do we identify, or I guess lab side, how do we identify Candida auris in the micro lab? Are current lab methods reliable? Next, perfect. So identification of Candida auris was very challenging in the beginning. It was often misidentified as other species like Candida hemolonii or Candida duobus hemolonii, but luckily that has improved greatly over the years, especially as it's been incorporated into more identification databases for many microbiological methods. However, we recommend confirming by MALDI-TOF or sequencing. There are also several FDA-approved panels for blood culture that can be used and have been FDA-approved, including BioFire and GenMark. And I think T2 Candida may also be including Candida auris soon as well. Colonization screening, it can be done by culture or PCR. PCR is preferred because of quicker turnaround time, but there is no FDA-approved test available at this time, so it would need to be a lab-developed test, which many clinical labs have done, and it's performed at all of the ARLN-funded public health labs. And there are materials on our website for this, and in the ARLN regional labs or our CDC lab are available for questions if anyone needs support or has questions about how to do that validation. And another challenge is that many clinical labs do not speciate Candida or yeast from non-sterile specimens because often it's not treated. And, you know, that makes sense for patient management, but for public health, it may be missing some cases of Candida auris that may just be identified in clinical non-sterile specimens. So consider doing this, even if it's just for high-risk patients to improve identification. And we know some areas that this method actually helped them to identify their first case in the area. So I think that's it.
Thank you very much, Dr. Lyman. That was a great presentation, answering many important questions. I do want to emphasize that if you have any other questions for Dr. Lyman, we would like to see them in the Q&A function. So as we speak, please feel free to add your questions in the Q&A function. For those of you that don't know me, my name is Luis Ostrowski. I'm a professor and chief of infectious diseases at UT Health here in Houston. And I have a particular interesting combination of skills because not only am I a mycologist, I'm the director of the Laboratory of Mycology Research in UT Health, but I'm also a hospital epidemiologist, and I'm the chief of epidemiology for Memorial Hermann Healthcare System. And I'm going to be addressing the infection prevention and control Q&As. Next slide, please. And these are my disclosures. And next slide, please. And first of all, I'd like to start with what we used to know about Candida. And this is how we typically thought that Candida transmitted in hospitals. We always thought about Candida as an endogenous infection, where your own flora, the one you carry in your skin or your GI tract, would go into the catheter or translocate from GI sources and cause your Candida infection. In fact, outbreaks with Candida used to be very rare, primarily being reported in neonatal ICUs. And this is one of those infections that has been traditionally related to artificial nails. Again, there's multiple old outbreaks in the literature relating Candida to artificial nails and neonatal ICUs. Next slide, please. However, last time we looked at our epidemiology here in our hospital, we found 107 cases of candidemia. And as typical in the literature, most of our patients were very sick with an Apache 2 score of 18 in mean. Very prolonged length of stay in the hospital, prolonged ICU length of stay. Our mortality was typical, 26%. Most of our cases were in the ICU. And our epidemiology was typical for the epidemiology of that time, with about 50% of the cases being Candida albicans, 20% glabrata, 14% tropicalis, 12% parapsilosis, and an odd case of Candida krusei. However, when we looked at genetic fingerprinting of our isolates, we found something really, really interesting. 26% of our isolates were related to another isolate in our collection, which actually meant that we were having troublesome transmission within the hospital. And when we did the detailed genetic analysis, we found about 11 clusters that comprise of 2 to 4 isolates each. So again, if you're normally working hospital epidemiology, this pattern would be very difficult to discern. But when you're working with molecular tools, and now we have whole genome sequencing in real time, this really tells you that the dogma of endogenous infection may not hold true anymore, and Candida may be transmitting and may be having reservoirs in different areas of your hospital. Next slide, please. And now we're going to start with the guidelines. This is a nice comparison between the CDC and the NHS guidelines, Public Health England. And as you can see here, both guidelines recommend that patients are isolated in a single room with standard and contact precautions. So that's the level of precautions you need for these patients. They do recommend surveillance cultures in a unit where you find a case. And for the most part, we recommend using axillary or groin swabbing as a main sort of surveillance mechanism. But in reality, you can also do other non-sterile sites like wounds, urine, as has been described in the literature before. Duration of contact precautions. There's a discrepancy here. CDC has changed this more recently, and we now recommend isolating people indefinitely for Candida auris because of some data that I'm going to show up ahead. As far as environmental disinfection, we knew very early on that anything that worked for C. diff worked for Candida auris. And what's important is to be really thorough and clean the environment very thoroughly, but not only the environment, but equipment, particularly equipment that travels from patient to patient, like thermometers, computers, ultrasound machines. That's where the emphasis is for cleaning. And again, terminal cleaning would be done with things that are C. diff rated, now Candida auris rated, but we had considerations for advanced cleaning technologies like hydrogen peroxide or UV light after full cleaning and disinfection. Next, please. So the first question I want to address from the ones that were submitted ahead of time, we had a question that said, should we be screening on admission all patients or based on risk factors? And currently, the CDC does not have a blanket recommendation to screen patients on admissions to the ICU or to your hospital. But what you should be considering is if you know of facilities that are having outbreaks in your area, in that situation, you would be falling within the CDC recommendations of screening close healthcare contacts of known cases. And the other recommendation that is very interesting is that CDC currently recommends screening people that may have had an overnight stay in a healthcare facility outside of the United States in the previous year. Although this recommendation is aging very quickly because now we have indigenous spread of Candida auris within the United States. So this sort of travel history may not be as relevant now as it was when these first guidelines were put out. Again, the emphasis currently is to screen close healthcare contacts of known cases. If you're aware of a facility near you having a cluster of Candida auris, it would be totally reasonable to screen patients on admission, although this research is ongoing and we need to really have more data to see if it's worth it to do. Again, because when you have low incidence, the number needed to screen becomes too high, and this has in other MDROs proven to be not as beneficial, and it really, really depends on the baseline incidence of disease that you're looking at. Next slide, please. Question 2 is if you have one patient on your unit that becomes positive for C. auris, should the rest of the patients on the unit be screened? What do you do if you find more cases? So this is epidemiology 101, hospital epidemiology 101, which is basically once you identify a case, you isolate, that's the most important thing, and then you do case finding to see if you have other cases within your unit. So the typical approach would be to isolate your patient. Contact precautions is the level of precautions we're recommended. Ideally in a single room. If you don't have single rooms, we typically recommend cohorting patients with similar diseases in the same cohort area. We emphasize the use of gowns and gloves and ideally monitoring the compliance with this. Some units have chosen to have kind of a red line or a control access area where anybody crossing this red line, and this is particularly useful for cohort areas, has to be wearing the right PPE. We really reinforce hand hygiene. We do a special in-services in the area that is housing a Candida auris patient so that people understand the importance of hand hygiene in this situation. And we coordinate with environmental services to do deep cleaning with anything that is rated for Candida auris. And again, special emphasis in not using quats, which are not effective against this disease, and in cleaning not only the environment, but equipment, and especially traveling equipment that may be going from patient to patient. We want you to be in contact with your health department so that we are aware of what's happening in your city and begin to identify networks of transmission. And again, this is very important. We want you to screen other patients in the same unit, or maybe that have left the unit, but were contemporary to that patient for colonization, because this strategy of search and destroy or search and isolate is going to be the way to avoid an outbreak in your facility. When your patient is being transferred to another facility, we want you to inform the facility that this is an incoming patient with Candida auris, which is the way we avoid spread throughout the city. Next, please. Question 3 was, what are the best cleaning options for Candida auris? And I want to point your attention to 2 resources that you will find within the CDC website for Candida auris. These are 2 lists that take you to the FDA website. One is cleaning agents that are rated for Candida auris and cleaning agents that are rated for C. difficile. Both work very well in this setting. And in general terms, what we want you to focus on are bleach-containing products, knowing that these products need to be stable, so they need to be recently reconstituted or those formulations that are stable over time. They have issues about light exposure and drying time. Hydrogen peroxide products work really, really well in this area as well. And even alcohol-based cleaning solutions seem to work very well for Candida auris. So again, anything you find in this list will work very well for this agent. And the key here is the thoroughness of cleaning, and using checklist goes a long way in not missing any surfaces when you're taking care of these patients. Next slide, please. And the question is it worth it to do advanced cleaning solutions like UV light or hydrogen peroxide misting systems? And the data are pretty strong. At least in vitro, we have a direct correlation of exposure time and intensity with decreasing Candida auris viability. Same with hydrogen peroxide, but actual research in healthcare settings is still very flimsy at this time. In our healthcare system, we do try to use these technologies because they're available to us. And although there's starting to be some concerns in the literature about some clades being more resistant to others to UV light, at this point, we have no clinical indication that that's the case. And I'm still recommending to access this advanced cleaning technologies if they're accessible to you. They really get everywhere, and you don't miss things when you're cleaning with checklist. Next, please. Question 4, does antimicrobial stewardship control or prevent C. auris? And there's very little data for antimicrobial stewardship interventions with C. auris. What we do know is that C. auris goes hand in hand with other MDROs. It is actually expected to find C. auris in coexistence with MDRO gram negatives, with VRE. All of these are latecomers into the course of a patient's continuum in the acute care or long-term care setting. This sort of antibiotic blasting creates the ecological niche for Candida auris as well. So it is natural to think that having good stewardship will have an effect in sort of incidence and propagation of this disease, but we don't actually have the evidence that a stewardship program will have an effect in the incidence of Candida auris in your facility. Again, this is an area of research that is going to be very important going forward. Next slide, please. And question 5, very, very important. I alluded to this question in the guidelines section, is how long should patients be on precautions? Can you clear colonization? And again, data are very scarce, but this is an article I want to point your attention to. This is a description of emergence of Candida auris in Chicago through a very, very detailed analysis of patients and their movement between acute and long-term care facilities. And what these researchers were able to show is that you have a good chance of being able to acutely clear colonization in a patient with Candida auris, but over 50% of the patients became recolonized within a year. So with a 50% relapse rate in colonization, it's very hard to think that we can be very reliably decolonizing our patients. And the current recommendation is to keep your patients in precautions indefinitely. And I know this is very hard because this is an obstacle to patient care, and it's an obstacle for care management, moving patients between facilities. But nevertheless, it is the default stance and the most safe stance to carry on at this point. I believe this is my last data slide. I want to thank you for your attention. And again, I want to remind you to please put your questions in the Q&A function. And next slide, please. It is my pleasure to turn it over to Dr. Yoon, who's an assistant professor in the Department of Medicine and Infectious Diseases at Albert Einstein College of Medicine. Dr. Yoon is going to talk to us about clinical management of Candida auris cases. Take it away.
Thank you. So I'll start with the first question. What is the treatment of choice for C. auris fungemia? Next. So as mentioned earlier by Dr. Lyman, most strains of C. auris in the US has remained susceptible across different clades. So it remains to be our first line therapy. What's important, however, is that resistance is easily acquired while on therapy, and we have seen rise in incidence of decreased susceptibility. In the recent Annals paper by Dr. Lyman, there was a note on 3 times greater resistance to echinocandins in 2021 prior to prior years. So this is a concern, which means that careful monitoring is important while the patient is on therapy. Cultures needs to be repeated. Susceptibility testing needs to be repeated, especially if the patient's not doing well. And if the patient's unresponsive to echinocandin or has persistent fungemia for more than 5 days, the recommendation by CDC is to consider switching to liposomal amphotericin B. Next. What about pan-resistant strains? So data is really lacking about the most appropriate therapy for pan-resistant isolates. In the laboratory setting, there's been various combination antifungal treatment that has been tried with promising results, but it has not been really evaluated in clinical settings. So we really don't know how to use it in the clinical setting. There are a number of promising investigational drugs, however, that I will be discussing later that may give us more options in the future. Next. Next question, can you use voriconazole or posaconazole if MICs are low, even if fluconazole MICs are high? So that's a good question, knowing that there's a rise in resistant, multi-drug resistant pathogens, and also depending on where you are geographically, the azole MIC may be lower, so it may potentially be options. But the basic answer is it depends. Next slide. So we don't have defined clinical breakpoints for azoles or antifungals in general. CDC has recommended tentative breakpoints depending on what's finding from other Candida species and expert opinions, but we really don't know how it correlates clinically. But there are tentative breakpoints for fluconazole, amphotericin, and echinocandins. For voriconazole and other second general triazoles, there's no breakpoints recommended. So we refer to fluconazole tentative breakpoint to make the decision. And on occasion, those that are resistant to fluconazole may respond to other triazoles. So it has to be considered on a case-by-case decision or considered as a combination therapy. Next slide. In fact, there are promising in vivo and in vitro data that other second generation azoles may have efficacy. There's a neutropenic mice model where voriconazole or enidrolafungin had improved survival and reduction in kidney tissue burden. And in vitro setting, as I mentioned earlier, there's been various combination therapy that has been tried with azole and echinocandins. So voriconazole, posaconazole with echinocandin, there has been positive synergistic interaction that's been found. But again, we don't know how this applies clinically. And we may have more other better therapies in the near future with the emerging novel therapeutics. So hopefully this will have better options in the future. Next. Third question, is C. auris really a virulent pathogen? We saw some patients never clear C. auris fungemia, but they got well and went home. So that's really good, but I think this is more of an exception than the norm. But this question gets to a key point that clinical outcome, it doesn't depend on pathogen virulence itself, but there are other factors that matters, especially host factors in the case of C. auris. So this question does bring up good points. So what are some of the virulence factors? C. auris has multiple virulence factors that's been studied in various animal models, Galleria, mice models, and some models suggest that C. auris is not as virulent as C. albicans, but more virulent than C. glabrata. But in some Galleria mice model, it says that it has been reported that C. auris can be as virulent as C. albicans, which is the most virulent Candida species. So C. auris, it shares number of virulence factors as other Candida species, such as enzyme secretion. lipases, proteinases, phospholipases, also tissue invasion. But a key virulence factor of CRS is biofilm formation, which is a complex microbiome community. And while CRS biofilm is not as complex or robust compared to that of C. albicans, it can hinder drug penetration. It can lead to antifungal tolerance, where a subpopulation continues to survive and grow while on therapy. So this really leads to persistence, leads to survival, adherence on surfaces in plasma materials. Also, CRS can aggregate, which contributes to this adherence and survival. Although interestingly, the non-aggregating form tends to be more virulent, but the aggregation leads to survival. Also, CRS, it can grow in high temperature, 42 degrees. It tolerates salt. So it really can survive in harsh environment. Also, while it does not transform to hyphae like C. albicans, it does undergo morphogenic transition to filamentous form, although we really don't know what that means clinically. Importantly, CRS can lead to immune invasion. Studies have shown that if there's C. albicans and CRS, C. albicans attracts neutrophils, phagocytosis, the innate response. But CRS, it does not. The neutrophils don't go to CRS, which may explain why neutropenia is not necessarily the major risk factor that we think about with CRS, and which may explain why some patients, despite antifungals, they don't do well because they cannot generate the innate immune response. So these are important virulence factors which may not be as robust as C. albicans. It really allows CRS to survive, persist in surfaces for 4 weeks or longer, and has important clinical implication. Next slide. So a number of studies have looked at how patients do with CRS. And here I highlight 2 major studies that compares patient outcome in those who are fungemic with CRS compared to non-CRS. One study recently published in New York, multi-center study from Brooklyn, and then in a little bit older study from Pakistan. What's interesting, notable, is both studies shows that mortality with CRS is not greater than that from other non-RS Candida, especially including albicans, glabrata, tropicalis, and parapsilosis. But what's notable is that those with CRS has more persistent infection or recurrent infection 60 days afterwards. Also, the infection happens long time into hospital stay. It's not immediate, but after all the nosocomial exposure, that's when they get it. And what were the major factors associated with CRS? As mentioned earlier by Dr. Lyman, Ostrowski, it's really associated with concomitant MDR bacterial infection. These patients are often on broad spectrum antibiotics already. They have history of prior colonization with CRS or other MDR bacteria. And less likely to be associated with typical factors that we associate with Candida, like TPN use or GI surgery. Those were less of a risk factor. But overall, the findings suggest that CRS, it may not really behave the same as a typical Candida albican or Candida glabrata we think of, mostly catheter or TPN. But these behave more like MDR bacteria. They're in the skin. Extensive antibiotics is associated with CRS. So these findings make us think like what would be the best way to deal with these infections. Next slide. What's striking is that in the clinical studies, both studies that I mentioned, all those isolates were echinocandin susceptible. But despite that, there's recurrence, persistency, meaning that there's additional factors. Of course, the virulence factors that I mentioned earlier, like biofilm, antifungal tolerance leads to this, but also the host factor really contribute to the poor outcome. We're dealing with a patient population who had extensive healthcare exposure as reflected by their MDR bacterial infection and extensive antibiotic exposure. So these factors really highlight that there may be we need to address potentially modifiable risk factors. As mentioned earlier, probably appropriate antimicrobial use, antifungal, antibacterial stewardship. Also, source control with Candida infection, that's always something that's important. Remove the lines, the catheter. Also, it's really important to do serial monitoring of antifungal resistance or tolerance. It has come up repeatedly that Candida, they can develop resistance while on therapy relatively quickly, and that may contribute to poor outcome. There are other research questions as well. We've noticed that it takes, there's a prolonged period while patients in the hospital before they develop this C. auris candidemia. Is there a way that we could have diagnosed it earlier or risk stratify earlier? We really rely on blood cultures, but we know that the sensitivities are poor with Candida. Also, there's a big host factor. Is there a way to augment immunity? Those are some of the questions that we may have more answers in the future. Next. Fourth question, how do you treat Candida auris UTI? Next slide. That's a good question. And I think ID consultants may agree that one of the most common questions that we get in the hospital setting is, there's Candida in the urine, what are we supposed to do? And there's standard set of questions that we would ask. Does the patient have a catheter? Is the patient doing okay? Is the patient on broad spectrum antibiotics? And the reason is Candida in the urine almost never is a real infection. It's often colonization, contaminant. You remove the catheter and that itself treats the candiuria. And also Candida from non-sterile sites, as mentioned earlier, is not always identified to the species level. So we probably often are missing C. auris in the urine. But because of Candida being often contaminant colonization, really careful clinical decision is required to decide whether this really needs treatment or not. If this is non-invasive colonization, CDC recommends against treatment. But in the right clinical setting, in the ICU, critically ill, immunocompromised, I think the possibility of disseminated candidiasis should be considered and get a blood culture to check. Next slide. So the management change, removing catheter, often 20 to 40% of the time, that itself clears the infection. Discontinue unnecessary antibiotics, treat other predisposing conditions. And if we really think that the patient has a Candida UTI, then there are options. Although there's limited data on this, and this is mostly based on expert opinion and how we treat other non-albicans Candida UTI, echinocandins would be one of the first option given the known resistance to azoles. However, echinocandins, it has minimal urine penetration. Although studies done in glabrata or other non-albicans UTI shows that echinocandin can be successful, but we may consider using higher dose. Amphotericin B deoxycholate is a good option. Unfortunately, liposomal amphotericin B does not penetrate well, but AMPO-B, it targets mammalian cells as well, so there's toxicity. Flucytosine also is an option, but there are toxicities. Combination therapy, as with fungemia, can be considered in cases where this is real and severe, such as azoles with echinocandins or flucytosine with AMPO-B. AMPO-B bladder irrigation is an option, but that's really the last resort, and that's rarely done. Next slide. And then the last question is, what new antifungals are available or in the pipeline for C. auris? Next slide. So what's exciting is that there has been development with new development of new drugs. One of the most promising one is ibroxafungerp, which is the first member of the triterpenoid class. It's similar to echinocandin. It's a glucan synthase inhibitor, but binds at a different site, so it does not have cross resistance with echinocandins. One major advantage is orally bioavailable, and it has activity against the biofilm. And it's stable against FKS mutation, which confers resistance to echinocandins. And recent phase 3 trials have shown promising interim analysis where 80% of the individuals with CRS had a positive outcome. And in cases where we don't have any other options, expanded access program is available to use this drug. Next one is rezafungin. It's an upgrade from echinocandin with enhanced PK/PD that allows once weekly dosing. The half-life is greater than 130 hours. It has potent in vitro, in vivo activities, but it is an echinocandin, and there can be cross-resistance because it has reduced activity against FKS and FKS2 genes. Another one is fosmanogepix, which has a novel mechanism of action of inhibiting the cell wall GWT1 gene that makes the cell wall frail, and it has broad spectrum and active against highly resistant fungi, and it has IV oral penetration, oral formulation, has high CNS penetration and high oral bioavailability. And this one is available through expanded access program as well. Next slide. Also exciting is that there are other ongoing research on immune-based approach that can adjunct antifungals, given that we continue to see high mortality while on antifungals. A group is looking at immune checkpoint blockade. There's also research on using IVIG with anti-candidal antibody or monoclonal antibody against cell wall epitopes. So I think the future is promising. Okay, that's it. Thank you.
Thank you very much. That was a great presentation for somebody who's actively treating Candida auris patients. And I want to thank Dr. Lyman. She's been very busy answering some of your questions in the Q&A function. So if you want to look at some of the answers that are available there, we do have some time, a few minutes for live questions. And I'm going to start with a really interesting question from Dr. Alobedi. Should organ procurement sites screen for Candida auris in potential donors? Dr. Lyman, what do you think?
That's a great question. And I think we don't yet know the impact of Candida auris for organ donation, but we do know of cases. There's one in particular, and I will put that in the chat, where a lung recipient, there was a donor-derived infection of Candida auris from a lung donation, and the recipient received it. And I've heard of one other similar instance. So I think that that is something that we don't yet know a lot about, but we've at least seen one possibility of it. So I think definitely an area we need to explore.
Yeah, definitely. So definitely one of those where incidence and impact enter into the equation. And if you're in an area that has a lot of cases, that's a consideration, but it's fortunately not a very frequently described donor-derived infection so far.
And maybe also just because a lot of the patients who get Candida auris are so sick at baseline, they might not be donating organs frequently.
Perfect. We have a question from Suzanne Gibbons-Bergner, who is asking about healthcare worker colonization with Candida auris. And I'm happy to report that in the Royal Brompton outbreak, this is a UK outbreak, they were very thorough about screening staff in that hospital. And they found basically less than 1% incidence of staff infection or colonization. So at this point, we're not really recommending the need to screen the staff. What we do recommend is emphasizing the use of PPE and hand hygiene. That goes a long way in avoiding self-colonization. There's another question about gel sanitizer versus soap and water. And both work really, really well. Alcohol works well, and it's associated with improved compliance with hand hygiene when compared to soap and water. But some hospitals do choose to recommend soap and water as a higher level of precautions, the so-called contact plus. So again, both are very effective as long as people are doing them. Dr. Ibrahim is asking, any room for combination therapy, any case reports, especially for pan-resistant isolates? Dr. Yoon?
Yeah, the combination therapy, unfortunately, we don't have much clinical data, but it's mostly in vitro setting that there's studies on using azoles with echinocandins or flucytosine with echinocandins that shows synergistic interaction, but it's how that applies clinically, we really don't know.
Very good. Question for Dr. Lyman. Do you have any recommendations for long-term care facilities being asked to accept patients with a history of C. auris?
Yeah, I mean, it's mostly just making sure infection control practices are good and ensuring good compliance. There are a lot of facilities that have cared for patients without seeing spread. So I think it's just important to communicate effectively about patient C. auris status. And there's no reason that if you can't take care of a patient who has C. diff or CRE, you should be able to take care of a Candida auris patient too. Again, focusing on good hand hygiene, transmission-based precautions, and or enhanced barrier precautions, and good cleaning with a disinfectant. So, just making sure those practices are in good shape.
Very good. And there's another question directed to me, but I think you're the best person to answer this, Dr. Lyman. In one of the part of the presentation, we highlighted that a lot of the patients were male and Hispanic. Is there any increasing prevalence in this demographics that you know of?
Mostly what we've seen is that gender is pretty split. The data we get nationally is pretty limited. So we have not seen anything nationally to suggest certain races or ethnicities. I think it probably reflects the population who's in long-term care based on the area. So I'm sure there's some difference based on certain geographic regions.
Very good. Another interesting question. Any specific recommendations for surgical skin prep in patients known to be colonized with C. auris? And I'll let you both give us some thoughts about this.
Well, I can talk a little bit about chlorhexidine. Mostly we talk about chlorhexidine bathing, not necessarily for surgical skin prep, but there are studies that have shown that very high concentrations of CHG will kill Candida auris. But some studies that have actually tested CHG levels on the skin have found that often it doesn't achieve the levels needed to kill Candida auris. So we don't specifically recommend CHG bathing for Candida auris control. That being said, it might be appropriate to use for other reasons, for other pathogens or generally for line care. So we're not saying don't use it, but it has not proven to be the magic bullet for C. auris, and we've seen outbreaks and transmission in facilities doing CHG bathing.
Very good. There's a question I'd like to take here. Could you please comment on what, if any, contact precautions in colonized patients returning for outpatient follow-up? And this is a very interesting question because outpatient infection prevention is always kind of the forgotten child of infection prevention. And there's outpatient and then there's outpatient. So clinic visits, we only recommend, for the staff to quickly wipe with something that is active against Candida auris after the patient visited the clinic. But when we're talking about coming to a chemotherapy suite or infusion or imaging, gets a bit more complicated. And for those cases, we typically recommend scheduling the patient as the last case of the day, therefore giving an opportunity for a deep clean or terminal clean after the patient finishes their consultation or infusion or imaging procedure. So very, very important emphasis on the outpatient space. We have another question for Dr. Yoon. This is an important one for you. How have you approached patients with persistent fungemia due to Candida auris.
Right. So I assume we're getting repeat blood cultures. It's persistent. I think repeat susceptibility testing is important. I will be concerned about they're developing resistance. Also, source control is the major one. There biofilm and control source. If it's unclear, maybe there's a need for like repeat imaging. But I think looking for susceptibilities and source control would be where I would start.
Very good. Well, it looks like we're at the top of the hour. So again, I'd like to thank the more than 230 participants who joined us in this webinar today. I want to thank the CDC for funding Terra Nova, for putting together this webinar, and the MSGERC for coordination of this Grand Round series. And most importantly, I'd like to thank Dr. June and Dr. Lyman for giving us their time today to share their knowledge. Thank you very much.